Hello friends, I'll discuss one important topic, that is bronchoscopic anatomy of airway. This is a very basic topic in field of bronchoscopy. Every resident, every bronchoscopist should know anatomy of airway. This is very basic topic. Everybody should know. So this is important topic. So I'll make video in Hindi also. So let's see. So prior to bronchoscopy, before doing bronchoscopy, we should know the reach of our bronchoscope. So in adult bronchoscope, where we can reach by our adult bronchoscope. I am not talking about pediatric bronchoscope. So adult bronchoscope can reach up to segmental bronchi, very important. Okay, so this is trachea, this is carina, this is right main bronchus, left main bronchus. After main bronchus, this is upper lobe bronchus, middle lobe bronchus, lower lobe bronchus. After bronchus only, there are segments. These are also called bronchopulmonary segments. So normal adult bronchoscope can reach up to segmental bronchi or bronchopulmonary segments, while pediatric it can go more distally. So basic things we should know. So talk about bronchopulmonary segments. These are 10 in right side, 9 in left side. These are typical teaching in our MBBS day in anatomy class. Okay, so in right side there are three lobes: upper lobe, middle lobe, lower lobe. In left side there are two lobes: upper lobe and lower lobe. In right upper lobe there are three segments, three bronchopulmonary segments. These are apical, posterior, anterior. So apical, posterior, anterior. One, two, three. We have to remember which segment lies on which numerical value. Means 2 is posterior, not 2 is anterior. 2 is posterior. 3 is anterior, not posterior. So we have to know numerical value along with name of bronchopulmonary segments. In middle lobe, there are two segments. Lateral side is lateral segment, medial side is medial segment. 4 and 5. 4 is lateral, 5 is medial segment. Lower lobe, there are 5 segments: superior, then basal segments: medial basal, anterior basal, lateral basal, posterior basal. Okay, so these are basal segments. In left lung, in upper lobe, there are 5 segments. Again, lower lobe, there are 4 segments. Okay, so upper lobe, there are two parts: superior division and lingular division. We will see in bronchoscopy. So superior division, there are 3 segments: apical and posterior. So many patients, they are fused, act as a single opening. So this is apico-posterior, segment 1 and 2. 3 segment is separate, anterior segment is separate. So there are 3 segments: apical, posterior and anterior. In lingula, they are superior, inferior. Is superior and inferior, not medial lateral. Medial lateral is right side, left side is superior and inferior. This is the name difference between right side and left side. Inferior lobe or lower lobe are 4 segment. Which is absent? This theoretical question. Medial basal segment is absent in left side. Rest all 4 are there as similar to right side. So what are they? They are superior, anterior medial, anterior basal, lateral basal and posterior basal. 8, 9, 10. 7 is absent. Okay, so there are 4 segments in left lower lobe. So this is how 9 segments are there left side, and right side there are 10 segments. And one more thing we have to remember by its numerical value. The position of bronchus is on 5th is inferior in lingula, 9th is posterior, sorry, lateral basal. So we have to know each numerical value, place of segment, at what place the segment is lies. We have to remember, because in bronchoscopy we will talk about with this in this manner only. RB6. RB6 means superior segment of lower lobe. RB3 means anterior segment of upper lobe. RB9 basal lateral. LB6 superior basal left side. So likewise we will talk these segments by their numerical value. So before bronchoscopy, before inserting bronchoscopy, we have to see orientation of image. How to see? Just you keep your bronchoscope like in palm or like a hole. The anterior part of bronchoscope should be seen on superior segment of monitor, upper part of monitor. Upper part monitor means anterior segment of bronchoscope. Posterior segment of bronchoscope. This is anterior part, this is posterior part. Posterior part of bronchoscope should visualize in inferior part of screen. So superior part, anterior bronchoscope, posterior or the inferior part is posterior side of bronchoscope. So once we will insert like bronchoscope like this, we will not do mistake. Okay, this is very important things. Second thing is we should not enter forcefully. We have to go gently inside the airway. Once you put, once you apply force, it will cause trauma to the airway. It will cause pain. It will cause bleeding. And important thing, it may damage your bronchoscope. So you have to enter very gently. Do not apply force. Try to avoid touching the wall of airway because maximum receptors of cough are there on wall. So once you will touch the wall, patient will cough. And once patient will cough, you will be in trouble. And these three areas are difficult areas which is there while doing bronchoscopy. And I think every resident, every newly bronchoscopist have to realize these are three difficult areas. Like to pass bronchoscope from nasal cavity from beginning itself, very difficult from nasal cavity. Once you pass from nasal cavity, you will have difficulty inserting from vocal cord. Once you try to insert your bronchoscope through vocal cord, it will go to esophagus. It's a difficult area. Once you pass from vocal cord, it will be difficult to go to right upper lobe because this is more superior side. So these are the three areas. So if any new bronchoscopist or new resident, they are not able to pass from this area, do not get panic or don't take tension. This is normal. So you have to understand there is learning curve for bronchoscopy also. So initial part you will find difficult to insert in these area and later on you will pass very easily from this area. So these are different difficult areas. One more question many residents or many bronchoscopy used to ask, from which hand we should hold bronchoscope, is right hand or left hand? So I must tell you that there is no problem if you hold bronchoscope from your right hand or left hand. The first person who did bronchoscopy, who invented bronchoscopy, he was left-hander. That's why he hold bronchoscope from his left hand. Or from that time, so we are following same manner. We are holding our bronchoscope from left side. But if you are comfortable with your right hand, you can hold with right hand also. But in my personal experience, in my suggestion, try to hold bronchoscope from left side. Why? Because your right hand will be free for doing biopsy, for instilling normal saline or doing any procedure. Your right hand will be free. So try to hold bronchoscope from left side. So coming to anatomy. So before inserting your bronchoscope, which nasal cavity you will find patent? Okay. So the nasal cavity which is more wider, more patent, you have to choose that nasal cavity for inserting your bronchoscope. So how to see? You can see by torch or you can see by your bronchoscope itself. Just keep tip of bronchoscope here and you see which nasal cavity is more wider, more patent. Or else you can ask patient also which nose is more blocking, which nose is getting blocked frequently. The nose which is not getting blocked, you can choose that area, that side. So in this case, particular this case, left nasal cavity is more patent as compared to right nasal cavity. So we have to insert bronchoscope from left nasal cavity in this patient. And before inserting nasal cavity, just apply Jalocan jelly for smooth passage of bronchoscope inside the air. So how to insert? Just keep your bronchoscope tip here in nasal cavity and gently push. Let it go freely. It will go freely through nasal cavity up to glottis or epiglottis. Don't try to push bronchoscope. If you will push forcefully, it will cause bleeding from nasal cavity and patient will get panic. So don't try to push through nasal cavity. Or else what you can do, you that bend your bronchoscopic tip towards downwards, that little one. So once you insert bronchoscope, like bronchoscope downwards, now you will go like this. So in initial phase, you can bend your bronchoscope little downwards. It will you will find easy to insert bronchoscope from your nasal cavity up to epiglottis. Then this is bronchoscopic procedure. So this is that right nasal cavity I am inserting, and it will go freely. You will not understand anatomy, but it will go from posterior part of tongue, pharynx. It will go, and you will find this is epiglottis. So this is epiglottis, and below epiglottis you will find glottis. This is vocal cord. Okay, so there are two vocal cord. Anteriorly, it is epiglottis. Posteriorly, these are cartilage. In between them is vocal cord. It's two vocal cords, and there is false vocal cord. It was taught in our anatomy part. Okay, so this is vocal cord. Okay, so anterior part is conical, like this, conical. Posterior part is wider. Okay, these are the cartilage which helping adduction and abduction of vocal cord. So for inspection of vocal cord, we have to rule out any paralysis of vocal cord, which is caused by paralysis of laryngeal nerve. Okay, recurrent laryngeal nerve. You have to look for any fixation of vocal cord in any particular position, which is caused by any tumor infiltrating to vocal cord. So two things you have to look for in vocal cord. One is paralysis of vocal cord, one is fixation of vocal cord. Okay, you have to compare left and right side. Okay, so this is the glottis area. But before inserting in trachea, you have to look piriform sinuses, which is there in lateral part of glottis area. So this is piriform fossa. Okay, so we have to look our bronchoscope, this left piriform fossa, right piriform fossa, because many tumors you can find metastasis in this area, or you can find that foreign body in this area. So these are piriform sinus, just lateral to glottis. So how to insert bronchoscope inside the vocal cord? Just keep the tip of bronchoscope in anterior part of vocal cord and ask patient to take deep breath. Okay, once patient will take deep breath, this vocal cord get open and gently push bronchoscope inside. Okay, then even before that, you have to ask patient to say and produce any sound. The vocal, you can see vocal cord movement. So I tell you that vocal cord movement is adducting in case of phonation, and abducting means opening while respiration. So respiration, vocal cord will get open. For sound producing or phonation, the vocal cord will go in adducted position, or it will get closed. This is how we have to check the mobility of vocal cord. So now coming to trachea. So after for passing vocal cord, we have to keep our bronchoscope anterior part. Ask patient to take deep breath, gently push. So you will find a long tube-like structure. This is trachea. Anterior part, this is cartilaginous. Posterior part, this is muscular. So anterior part, once you go inside, you will find this is carina. Okay, this is carina. Carina, there are two opening. One is right side, one is left side. So my right is right main bronchus, my left is left main bronchus. So trachea, right side is right main bronchus, left side is left main bronchus. So little bit about trachea. So trachea is extend from C6 to T5 or T6, cricoid cartilage to T5, T6. Length is usually 10 to 12 centimeter diameter. It has 50 to 20 C-shaped cartilage, that to anterior side. Posterior side, there is no cartilage. This is fibromuscular structure, stripe-like structure in posterior part. Anterior part, these are tracheal rings, this C-shape. So one question arises in our mind, why trachea doesn't have complete cartilage ring? Why C-shaped? posterior part is not getting covered. Why? So we should understand that behind trachea there is structure called esophagus. So anteriorly trachea, posteriorly esophagus. In normal physiological condition or normal resting condition, esophagus is in collapsed state, while trachea is patent always because of cartilage ring. But esophagus is collapsed position in normal resting condition. Once somebody take food inside the oral cavity, when food goes in the esophagus, then esophagus dilate. Once esophagus will dilate, it will push posterior tracheal wall anteriorly. This is posterior wall of trachea. It will get come forward. It will come forward because esophagus will push. Suppose if you imagine if cartilage ring is circular, then it will not allow esophagus to dilate when while taking food. What will happen? Patient will have dysphagia. Patient cannot eat because esophagus will not dilate to accommodate food which we are taking in. Okay, that's why this is C shape. This is created by God so beautifully. So at Carina, we have to look anatomy of Carina. Carina normally should be sharp structure, middle and sharp. Okay, so if you find this widened carina, it is abnormal. It should be sharp and central. If it is widened, then it's abnormal. Probably this widened carina is due to enlargement of subcarinal structure like lymph node or any mass. So this is normal, this is abnormal. And you have to remember that most sensitive area for triggering the cuff reflex is carina. Okay, so try to avoid touching carina, otherwise it will create cough to the patient. So this is carina. So in carina you can see right main bronchus, left main bronchus. So what's the difference between two? So difference, right main bronchus is little wider, shorter and more vertical. It's more vertical. Okay, so structures like that, if somebody is taking some abnormal things, it it may lead to aspiration pneumonia because this is vertical. Whatever eat in trachea, it will go directly to lower lobe of right main bronchus, right bronchus. Okay, so more aspiration pneumonia in right side, while left side is narrower, longer, and more horizontal, like more horizontal. So there is less risk of aspiration. But the thing is, if there is infection in the bronchi, so secretion will not come out. It will cause bronchiectasis. So bronchiectasis is more common in left side of lung. Aspiration pneumonia is more common on right side of lung. So coming to secondary carina. Okay. So once you find carina on the this by bronchoscope, you have to rotate bronchoscope towards clockwise, towards clockwise 90 degree. So once you rotate bronchoscope 90 degree by clockwise, then you will find easy to go in right main bronchus. So this is carina. We will rotate 90 degree clockwise. Then first structure you will find is two opening. One is superior, that is right upper lobe, and another opening is called right intermedius or bronchus intermedius. Junction between right upper lobe and bronchus intermedius is secondary carina called RC1. Okay. In intermedius, you can find two opening. One is middle lobe, that is in left side or medial side. Lateral side, this is lower lobe. The junction between middle lobe and right lower lobe is RC2. This is also secondary carina but called RC2. RC1 is here, RC2 is here. This is secondary carina. So after seeing secondary carina, we have to see right upper lobe. For right upper lobe, we have to bend tip of bronchoscope anteriorly or superiorly, because right upper lobe is superior part, little bit superior. So we have to insert our bronchoscope right upper lobe. This is, yeah, right upper lobe. This is difficult part actually. So right upper lobe, you will find three opening. The apex or superior part is RB1, मतलब superior segment or apical segment. Right side, this is RB2. Left side, this is RB3. So this is how we are labeling as RB1, RB2, RB3. So you must be thinking that why posterior is not RB3, why RB2 is not anterior, why we are giving this numbering like that. So this is depends on origin. As I told you previously, this depends on origin. First, while development, first origin is apical segment. That's why they have given name 1. Then posterior 2. Then anterior 3. And you can see carefully the RB1 is superficial. Then RB2 is deeper. More deeper is RB3. This is how you can identify various segment in right upper lobe, RB1, RB2, RB3. So, so after inspecting right upper lobe, just slightly withdraw bronchoscope and keep bronchoscope at the opening of right intermedius. Once you keep right intermedius, you will find three opening. Okay, three opening. Upper part is right middle lobe. Upper part or medial side, left side. That is right middle lobe. In between, there is basal segments of right lower lobe, and you find small segment here. This is RB6 or superior segment of right lower lobe. So in this area, you can find two lobes. It's a middle lobe, it's a lower lobe. Lower lobe RB6 is different opening, all other has different opening. Once you slightly go inside in bronchus intermedius up to middle lobe, then you will find there is another opening in left lower lobe just beneath middle lobe, just near to middle lobe. So middle lobe, this medial segment, medial basal segment or RB7. Lateral most or right side, this is RB6. And three opening are here in this basal segment. ALP, alkaline phosphatase, anterior, lateral, and posterior. And this most left hand side, this is middle lobe. Okay, so middle lobe, medial segment, basal segment, then RB6 or superior segment. So let's come to right middle lobe. So this is upper lobe. We have to pull bronchoscope little bit out. Then we have to go inside the bronchus intermediate. This is bronchus intermediate. You can see this is middle lobe. This is lower lobe. In lower lobe, you can find this is RB6. Basal segment, this is middle lobe. Secondary carina. Yes, I told you earlier also. So after inspecting this bronchus intermedius, we have to navigate bronchoscope in middle lobe. So we are going middle lobe. So this is middle lobe. In middle lobe, you can find two opening. The lateral one is RB4, medial is RB5. The medial segment of middle lobe, lateral segment of middle lobe. So RB5, RB4. In 70% of patient, this is the nomenclature, left, lateral and medial. But there are anatomical variation is there in middle lobe. In 1/4 of patient, that 23% of patient, it is not lateral medial. This is superior inferior like lingula. Okay, so we have to keep in mind that there are anatomical variation which may change that orientation of your segments. So this is middle lobe. So right lower lobe. So as you know that right lower lobe, there are 5 segments. That is superior segment, then basal segments, medial, anterior, lateral, posterior, ALP. So there are 5 segments in right lower lobe. So if you see bronchoscopy, now our bronchoscope is in middle lobe. So we will withdraw little one. So it will withdraw. Then we have to insert in right lower lobe. So once you focus here, once you focus in right lower lobe, you will find two segments. The upper one or right side, you will find RB6 or superior segment. In another opening, you will find four basal segments. Okay, so four basal segment in lower side or left side, right side, one single opacity, that is RB6. So if you go little inside, then you will find two segments. Two segments. Okay, one segment is RB7, that is medial segment. So just near to middle lobe, there is segment that is medial segment. Middle lobe, medial segment, M for M. So just here it would be middle lobe, and just near to middle lobe is medial segment. While extreme right side is RB6. In between there are three basal segment. Here three basal segment, which are 8, 9, 10. ALP, alkaline phosphatase, anterior, lateral, posterior, in single line. 8, 9, 10. Here 8, 9, 10. So you can observe that here is middle lobe, that is RV5, 4 and 5, then RV6 here, then RV7, 8, 9, 10. They are all sequence. So 4, 5, then 7, 8, 9, 10, and 6 is somewhat in right side. This is how we have to identify segment in right lower lobe. So these are basal segment 8, 9, 10. 8, 9, 10. ALP, alkaline phosphatase. So we have to remember in this sequence only, then we will not forget. We have completed our right side inspection. Now we have to look for left side bronchus. Okay. So for left side, we have to withdraw bronchoscope from right side. Then we have to rotate bronchoscope anti-clockwise 90 degree at Carina. So once we rotate bronchoscope 90 degree anti-clockwise, we will direct towards left side only. So let's see our bronchoscopy. So this is right side. We will withdraw our bronchoscope inch by inch or centimeter by centimeter. We will reach at Carina. Then we will rotate to anti-clockwise 90 degree. This is left side. So once you reach left side from proximal, you will find two opening. One is upper side, one is lower side. And the junction between two opening, upper and lower, there is junction called secondary carina. Okay, so this is upper lobe, this is lower lobe. So this is upper lobe, lower lobe. And one more thing, then upper lobe, the first opening you find in lower side is lingula. Means if you see bronchus from proximal bronchi, then you will find upper lobe lingular opening, and in lower side you will find two opening, LB6 on lateral side and rest of the basal segment on medial side or right side. This is lower lobe, so we'll go inside the lower lobe. Lower lobe, this is LB6 or superior segment. So further, if you see, there may be many segments in LB6. This is subsegmental. Then we will see basal segments. So as I told you, there are four basal segments. There are three segments, four segments in right side. In left side, there are three basal segments. Which one is absent? Medial basal. So other are 8, 9, 10, ALP, alkaline phosphatase, anterior, lateral, posterior, from upward to downwards. So in left lower lobe, left hand side is LV6, superior segment. Right side, there are three segments, ALP, 8, 9, 10. This is how lower lobe looks like. Then we will go on upper lobe. Upper lobe, there are two division. Two division, lingula and upper lobe. And junction between lingula and upper lobe is again tertiary carina. So this is carina, tertiary carina, this is lingula, this is upper lobe. So lingula is medial side. As in right side, no, right side, medial side is lower lobe. Similar In left side, medial side is lingula. Okay, and lateral side is or left side is upper lobe. Okay, so once you see in lingula, you will find two opening. This is superior, this is inferior. In right side, it was medial and lateral, but in left side, upper one is superior segment, and this is inferior lingula, superior lingula, inferior lingula, LB4, LB5. This is lingular segments. We'll go upper lobe. In upper lobe division, you will find two opening. One is left side, another one is right side. Or here it is medial side and this is lateral side. Lateral side, there is opening of two bronchi, that is 1 and 2, apico-posterior, apical and posterior, open in one lumen. This is apico-posterior. Lower one or right side one or medial side one is anterior segment. Okay, so left upper lobe there are two opening, apico-posterior and anterior. So if you see apico-posterior further, you will find another two opening in apico-posterior. One is apex, one is posterior segment. So once we go inside, you can see there are two opening. So two opening LB1 means apical and this is posterior. So apical extreme left or lateral side. Medial one is posterior. So after inspecting apico posterior, let's see anterior segment. So just withdraw little bit, then just near to apico posterior. This is anterior segment. This is LB3. So if you observe, there are in all one line, LV1, LV2, then LV3, LV4 superior, LV5 is inferior. So this is how we have to locate lesion in left side. This is normal anatomy. So if you can see, this is lingula. This is upper division actually, upper lobe. Upper lobe, just medial one or right side is lingula. Lateral side is LV1 and 2 and LV3. This is anterior segment, this is apico-posterior segment. So likewise, we have to identify segment in left side also. So now we have identified all segments. But if you forget any segments inside or you just lost, come back to Carina because every segments looks same inside the airway. By bronchoscopy, all segments look similar. So very difficult sometime to identify which segment we are going in. So if you lost somewhere, just come back to Carina. In Carina, go again to look for that segment, right side, left side. So once you go from Carina, you will easily find which segment you are getting in. Another one, don't push or pull scope forcefully. Either you are going inside or coming outside, you should not use force. We have to go gently, otherwise there will be trauma and you may damage your bronchoscope. While removing, do suctioning because there are much secretion which are there, so we have to suck all secretion. Otherwise, patient may get aspiration pneumonia after bronchoscopy. So these are the basic things we should remember in while doing bronchoscopy. So if you like this video, please share with your friends. And if you are not able to understand, please see again and again. If you want to see in Hindi, I'll make video in Hindi also. So if you like this video, please like it, share it with your friends, and see you with another video. Thank you very much.